So next is Necrotising Fascitis V28. It is 1 a.m. 65-year-old diabetic male presented with painful red swelling in his right thigh and the groin. He is paraxial, hypertensive, and dehydrated. How will you treat him? So I will approach him with the CRISP protocol. Resuscitate him with oxygen IV fluid to large bore cannulas. Take all the bloods, and then I will take the history and examine the patient. And I will ask him from any trauma, IVDU, symptoms of bowel obstruction. Differential will be colitis, abscess, incarcerated hernia, neck fascia. If considering an infective etiology, commence broad spectrum antibiotics. What is neck fascia? So it's polymicrobial infection of the skin and fascia with necrosis of the subcutaneous tissue, sparing the underlying muscle. It can occasionally invade underlying muscle, causing a necrotizing pyomyositis. Can progress rapidly to severe sepsis, multiple organ failure, and death. Higher rates of necrotising fasciitis are seen in men, middle-aged, elderly patients. However, all ages can be affected. Risk factors include the diabetes, immunosuppression, steroids, old age, malnutrition, renal failure, arterial occlusive disease, intravenous drug abuse, body mass index, 5 recent surgery, or traumatic wound. How is necrotizing fasciitis classified? It's classified primary and secondary. Primary is due to bacterial entry from the mild skin trauma, and secondary is due to other deep abscess or vesical perforation. It can also be classified by microbiological findings. Type 1 is polymicrobial. Type 2 is caused by gas-forming organisms, streptococci alone and with the staphylococci. Type 3 are monomicrobial infection caused by Clostridium, and type 4 are fungal. So what are the clinical signs? So clinical signs, erythema, swelling, and disproportionate severe pain, and warning signs of the dusky blue skin, crepitus indicating gas in the tissue, patchy areas of necrosis, bullae, and signs of systemic sepsis. How would you confirm the diagnosis? So blood tests including FBC, UNE, LFT, CRP, clotting, albumin, ABGs. The laboratory risk indicator of necrotizing fasciitis, LRINEC score, is a scoring system encompassing 6 routinely performed laboratory tests used in conjunction with the clinical signs to support the diagnosis. So it includes C-reactive protein, white cell count, hemoglobin, sodium, creatinine, and glucose. The imaging soft tissue gas and the X-ray or CT scan. Although imaging can be useful, it does also lack specificity and should not be delay prompt surgical intervention when necrotizing fasciitis is suspected. Stab incision over crepitus releases murky fluid from the skin. How would you treat the patient? IV broad spectrum antibiotics should be commenced. The antibiotic choice should be guided by the local epidemiology and the resistance. Appropriate treatment include the beta-lactam antibiotics with clindamycin. If you're suspecting MRSA, add vancomycin, linezolid, daptomycin, and targeted treatment for streptococcal clostridium infection include the benzyl penicillin and clindamycin. The optimal duration of antibiotic has not been defined, but continue for 48 to 72 hours until debridement is done. Surgical debridement is the only definite treatment strategy. Take the patient to theatre following initial resuscitation. And early radical surgical debridement with the removal of all necrotic and infected tissue is imperative. If debridement is delayed, this can lead to poor outcomes. Operating early results in improved outcomes, shorter ICU and hospital length of stay. Take back in 24 hours for second look and after debridement, for further debridement. Can you comment on the other novel adjuncts to the surgical treatment, hyperbaric oxygen, IV immunoglobulins, and vacuum-assisted clear devices? Thank you.